Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Medtronic.
This program is presented by Medscape Education Global.
Hello, I'm Michael Block from Renal Institute for Heart and Vascular Health in Reno, Nevada. Welcome to this program entitled, How Do I Know If Renal Denervation is Right for My Hypertension Patient? Joining me today are Eric Sisemski, who's Associate Professor of Medicine at Harvard Medical School and the Director of Vascular Intervention at Beth Israel Deaconess Medical Center in Boston, and Tiffany Randolph, Director of Heart and Vascular Prevention at Moses Cone Hospital in Greensboro, North Carolina. Welcome to you both.
Thank you, Michael.
So perhaps, Tiffany, you can start us off just talking a little bit about the burden of hypertension and why that's important to our patients whose blood pressure is not controlled.
Absolutely. Well, the half of the adult population has hypertension, and unfortunately, less than about a quarter of the people with hypertension actually have their blood pressures controlled to goal, meaning less than 130/80. And that has a tremendous impact on downstream cardiovascular events, right? I tell patients that everywhere that there is a blood vessel, the hypertension is wreaking its havoc on those end organs, right? So it increases our likelihood of developing heart failure, heart attacks, strokes, chronic kidney disease, dementia, and so on. And what we know is that there is a very linear association between degrees of hypertension and control and downstream outcomes. And so by that, what I mean is that, when we go from having a blood pressure in the 130s to 140s, there is a step up in increased adverse outcomes, just as there is from 140 to 150 and so on. And that's only compounded when patients have underlying cardiovascular comorbidities.
Yeah, talk to us a little bit about how that interaction between uncontrolled high blood pressure and other cardiovascular risk factors, how that plays out.
Absolutely. So what we know is that there's a compounding impact, right? So if you have hypertension and diabetes and chronic kidney disease, those types of underlying risk factors end up combining to overall increase the downstream adverse outcomes of mortality, heart attacks, strokes, and so on.
So of course we should be striving to get our patients controlled, that is less than 130/80, but many patients don't reach that target. What can you tell us about the incremental benefits of lowering blood pressure by, say, 5 millimeters of mercury? What does that mean in practice in somebody who's not controlled?
Great question. So oftentimes we think that having just a small 5 millimeters of mercury may seem like not very much of a difference, right? But actually that leads to a 10% reduction in overall cardiovascular events. It leads to a 13% reduction in the likelihood of developing heart failure, reduced cardiovascular death, and even small numbers like that in change or improvement in blood pressure control can have tremendous downstream impact.
Yeah, it's something I talk with my patients about all the time. I think those blood pressure numbers can be quite abstract, but when you really talk about stroke risk, you talk about heart failure risk, it really can mean something more to those patients. So obviously there's this huge group of people who have uncontrolled high blood pressure. A subset of them actually have resistant hypertension. I wanted to just take a couple minutes and talk specifically about resistant hypertension. Can you just kind of take us through the definition of resistant hypertension and just a little bit about the initial workup of patients with resistant hypertension?
So when we say resistant hypertension, what we're really meaning is that people's blood pressures are not controlled to less than 130/80 on 3 medications, or that they're controlled on 4 medications. And even with that, we have to dig deeper and make sure that these patients are truly resistant and not pseudo-resistant, right? For many reasons, our patients sometimes are not actually taking the medications that we've prescribed. And we know that hypertension, unfortunately, is a disease process that frequently takes more than one medication to control. However, every time we give one more medicine, it decreases the likelihood that patients are actually taking them. So you can have pseudo-resistant hypertension where it's not controlled because the patients aren't actually taking it. You can also have white coat hypertension, right? We know it's very common for patients to come into clinic and their blood pressures are higher there than they are at home. So it's so important to check in multiple settings so that we have a better understanding of whether or not patients truly have hypertension, right?
And what about secondary cause, right? Should we be looking at secondary causes in most of these patients with resistant hypertension? What's a little bit of your approach and what do the guidelines say?
Absolutely. So the guidelines would recommend that anyone that has resistant hypertension be evaluated for secondary causes. One of the first things that we have to think about is hyperaldosteronism, because we know that's very common in that patient population. And so that means, checking renin and aldosterone levels for patients. Another thing that we think about is renal vascular disease. So we want to rule out fibromuscular dysplasia or renal artery stenosis. That can be done with multiple imaging modalities. Most patients would start with a renal artery ultrasounds or Dopplers. Other things that we want to think about too are other things that could be contributing to high blood pressure, like heavy NSAID use, alcohol, other contributing factors that could be not necessarily tested in every patient, but if there's a clinical suspicion like sleep apnea, or whether there might be underlying neuroendocrine tumors that could be contributing like pheochromocytomas, it would lead us down that pathway. We think about it for resistant hypertension, but it's also important to think about screening for secondary causes in people who are under age 30 who develop hypertension, especially if they don't have other risk factors or family history of early onset, or people who develop a rapid onset of hypertension even though they may be older or truly difficult to control blood pressures at a later age.
Sounds good. So Eric, I want to bring you into this conversation. I've been going around for longer than I want to remember talking about lifestyle modification, establishing a foundation of pharmacologic therapy in patients with resistant hypertension or poorly controlled high blood pressure. Talk to us a little bit about some of the limitations of those. We'll talk about those two pillars of therapy, about lifestyle modification and medicines. Why isn't that working? Why isn't that doing a better job?
Yeah, I think you guys set the conversation up really nicely where we have lifestyle interventions that can be very successful, but we also know that they can be transient. So we're all good maybe at going on a diet and losing 10 pounds and getting our blood pressure under control. But if we're thinking about the long term, keeping that weight off, managing some of our other behavioral aspects, they come and go, and blood pressure will respond to that. It'll come back up and it'll come back down. Medical therapy, has been referenced, is challenging. And right now we're living in this world of pharmacotherapy. We've got some really exciting new medications, but that list of meds is getting longer and longer. And we know, even in just focusing on antihypertension meds, that if you go from 2 agents to 3, it doubles your risk of non-adherence. So we've got a real problem because it's not that we don't have solutions, it's just that we don't have solutions that can be implemented consistently for the average person. And we've worked really hard on U2, in particular out in the community, trying to emphasize the role of these agents, but we've not necessarily bent the curve and got to the real goals that we want of getting blood pressure under control.
So I think you said it really nicely, right? We want to continue to promote lifestyle modification. We want to continue to promote good medical therapy in these patients, but we can't ignore adherence. We ignore it at our peril, and it's dynamic, and it's a problem we all face in our clinical practice. So we're excited, I think, to talk about this third pillar of therapy, right? We have lifestyle modification, we have medicines. Eric, tell us a little bit about this third pillar of therapy, what we have out there.
Yeah, so it's really, really exciting to be able to bring something new to this space. And again, not only because it's a therapy that can be not reliant on adherence, that can lead to durability and around-the-clock blood pressure control, but also just to have something to continue to raise awareness about the importance of improving blood pressure control. Even if you never get to the third pillar, which is now going to be called renal denervation, just having these in the toolbox to execute one at a time lifestyle meds, and after those 2 are exhausted, renal denervation is incredibly exciting and I think important for our patients.
Yeah, can you just explain to us a little bit about the procedure and what sort of the goals of therapy and how it interrupts the sympathetic nervous system, just to kind of set the conversation.
Yeah, it's great. We're not going to go into the exquisite detail, but I think the most important part of that is a lot of patients, most patients with uncontrolled hypertension, have some inappropriate sympathetic nerve activity. So there's some overactivity of our sympathetic nervous system, and we talk about norepinephrine spillover. And so we measure these high levels of norepinephrine. We see the effects that the high sympathetic activity that's really communicating with the kidneys results in vasoconstriction, sodium retention, and fluid retention, inappropriate responses that drive our blood pressure up. So in the 50s, when there weren't a lot of pharmacotherapies, there was actually surgical treatment to break off the sympathetic chain. Obviously, that was met with a lot of morbidity and mortality, and when a pill came around, it was an easy switch from surgical treatment to a medical therapy. But now we've really gotten to a space where we can access the sympathetic nerves and the renal arteries in an endovascular, minimally invasive approach and shut those nerves down just at the local level to reduce blood pressure.
So one-time procedure, right? Nothing left in the body, one-time procedure. And what kind of results have we seen with the clinical trials to date, both in terms of efficacy and safety? Can you?
Yeah, it's really exciting because, again, I'm an interventional cardiologist, so I do a lot of procedures. People are left with implants and stents. They're left with hospital stays. Sometimes it works, sometimes it doesn't, and there's usually some risk of complication. Renal denervation is quite unique. So the nice thing is the procedure, and I've done several dozen, takes about 45 minutes. People go home the same day. They're not left with anything in their kidney arteries. So the kidney arteries look the same as they were when they came into the lab. And again, as we'll talk about in a moment, it's a one-time therapy for a long-term solution. Now, renal denervation's come and gone in the US. We've seen trials that were successful. We then saw trials that were not successful. But in the last 5 years, we've encountered really the right technology and the right way to evaluate that technology that resulted in now 2 devices coming to the US market for commercial use. Now, these devices were first trialed in patients who were not on medications, and then they were trialed in people who were on medications. And so that's important to differentiate that. We want to see those who may never have started a hypertensive agent, and we want to make sure that that's like the proof of concept that this works. But really where it comes into play in clinical practice is in those who are on medical therapy. And we see really nicely that patients are getting right around a 10-point drop in their blood pressure at about 3 to 6 months. Really, that's about a really strong medical agent, maxed out or about maxed out. And then we've also seen, though, is that blood pressure is followed over 12 months, 2 years, and now even out to 3 years and beyond, that blood pressure response actually grows. So we've seen anywhere from 15 to 20-point reductions in blood pressure 2 to 3 years out now. So really exciting times because one-time therapy, no adherence issues, on around the clock, very safe and I think effective, and showing long-term results now that are meaningful to the patient.
And yeah, we'll talk about both your clinical experiences with this technology here in a moment and the results that your patients have had. But we talked earlier about, about 10 millimeters reduction in the office from baseline. We were talking a little bit about sort of unmet needs and hypertension earlier. What can we expect if that's maintained over time? Does that seem to you, Tiffany, like a clinically meaningful reduction in blood pressure? What's that going to mean for patients?
So that's a great question, and what it really makes me think about is the SPRINT study, where we see that obviously the landmark trial where the group who was treated to intensive therapy did much better than the group who was allowed to have more standard blood pressure control for the time. But once the study actually wrapped up, what they found was that when you continue to follow these patients in a non-clinical trial setting, both groups pretty much ended up with blood pressures around 140, which we know is not ideal. That is really contrasted with the data that we see with renal denervation, right? So as Eric mentioned, by 3 to 6 months, you see about 10 millimeters of mercury of improvement, but the longer term data shows that even once these patients are not in an intensive study environment, they have even better blood pressure control than they did earlier on. And so clinically, to me, knowing what we know about how lower blood pressure control, even by 5 or 10 millimeters of mercury, translates to improved outcomes, this is what's actually most exciting to me.
Yeah, I think it's one of the questions I get a lot about this technology is, for reasons of clinical trial design, we wanted to have a short-term primary endpoint for most of these studies, but durability is obviously super important. So, Eric, do you have any other thoughts? Tiffany, you said described that very nicely, the durability. Any other thoughts about the durability of the procedure, what we've seen from the clinical trial?
No, I love that
data?
comment. And, I think the nice thing is we've seen that durability without an increase in medication. So it's not just that people are like, I got a procedure done, I'm going to be really good now, and if I have to keep going up on my meds, I will. It's like back in the real world practice that they're on their meds or they come off some if they're lucky, but more importantly, they have that improvement over time. The one thing I also like to tease out a little bit is we present this as an average, right? We take the whole group and we say the whole group did 10-point reduction. In renal denervation, though, we've seen people who might have a smaller reduction, but we see a lot of people also have very large reductions, and they're hard to pinpoint who they are. But we have some people who come in and they end up having a 30 or 40 point drop. And I think as we understand this technology better, we'll be able to tease out who those patients are. But just that the promise is there that, again, we're not curing hypertension and we're not trying to get rid of the other two pillars of lifestyle medical therapy. But there are people who can have a really, high magnitude of result from this therapy and can really change their future.
Yeah, I agree. And really, I think the one predictor that we've seen in study after study of people who are going to get the best results in terms of magnitude of blood pressure reduction are people who have the highest blood pressures going in. So certainly that's, I think, a part of the decision-making process. So, we have a procedure that is effective. We have a procedure that's very safe. I don't know if we talked a lot about safety, but the safety has been very well demonstrated in clinical trials. And we've really seen now that kind of concepts be disseminated now into our clinical guidelines. I mean, there's an alphabet soup of guidelines that are out there worldwide that have really changed the landscape over just the last 6 or 7 years. 6 or 7 years ago, guidelines said renal denervation wasn't ready for prime time, but now we see guidelines from all over the world that are trying to help us decide which patients are best for treatment with renal denervation. Before we kind of get into some of those guidelines, I thought maybe we could just talk a little bit about some individual cases. I know you've each brought a case with you today to share with us. Tiffany, you want to start with your case?
So I have a 46-year-old gentleman who came to me on very standard therapy. He was taking amlodipine at max doses, atenolol. He was on spironolactone as well as an ARB and a hydrochlorothiazide combination tablet, and had many underlying risk factors for cardiovascular disease. So had sleep apnea, was using CPAP, was a smoker, had diabetes, and hypercholesterolemia. And despite being adherent to his multiple drug regimen, his blood pressures were still averaging in the 160s consistently. And so when he first came to our clinic, of course, the first thing we did is the evaluation for secondary causes, right? Because he was on those 3 meds or more and uncontrolled. We did confirm that he was picking up his medications from the pharmacy consistently and took that as a surrogate for adherence. We referred him for renal Dopplers, which were negative for renal artery stenosis, checked renin and aldosterone levels, which were within the normal range, and did extensive counseling on limiting dietary sodium intake and referred him to a smoking cessation counseling, as well as got him involved with an exercise program. And so that first visit, the first thing that I did from a pharmacologic standpoint was add hydralazine, 50 milligrams 3 times a day, which, as we know, 3 times a day medication is not always helpful for adherence, but there weren't a lot of other options. And then we sequentially followed him. So we have a team of nurse practitioners and pharmacists who work with us, and subsequently increased his dose of spironolactone, increased the hydralazine, and he finally actually added doxazosin. Still, blood pressures moved by about 10 millimeters of mercury, still in the 150s at this point. And so at that point, we decided that it was time to refer him for renal denervation. We followed him up about a month and a half after the initial procedure, and his blood pressures were in the 140s, so certainly improved. But as we've continued to follow him over time, I was very happy to report that when I saw him last month, his blood pressure was around 135/85. So still not where we want to be, still on the exact same therapy he was pre-procedure, but his cardiovascular risk is substantially improved by undergoing the procedure.
So yeah, that's a really illustrative case, I think, of someone with resistant hypertension, uncontrolled despite escalating medications, confirmed out of office blood pressure, poorly controlled, ruled out secondary cause. And then can you talk a little bit about that shared decision making that you underwent with him? What did that conversation look like when you were talking about renal denervation with him?
Absolutely. So at this point, though he was adherent, he was not enthusiastic about taking more medications, especially knowing that so far each medicine we had given him really only gave about 5 to 10 millimeters of improvement at best. And so he was actually very interested in the idea of a procedure that would not require another pill to hopefully get him to goal. And one thing that I think is very important and that the guidelines would recommend too is just making sure that we don't have our own assumptions about who might want a procedure and who might not, right? Because patients often will surprise you and be interested in doing procedures. And one thing that I did talk with him about too was the safety profile, that overall there's a very low risk and there is not always a great predictor of outcome. However, the fact that he was so uncontrolled on multiple medications and blood pressures remained so high did certainly portend to potentially a better outcome. Unfortunately, it turned out that way for him.
That's great. I love the way you frame that conversation as an either or. Doing nothing is not an option. Poorly controlled blood pressure, either intensify your medications or consider renal denervation. So resistant hypertension, obviously very important case, very important indication for renal denervation. But we have other patients who may be good candidates for renal denervation as well. Eric, I know you have a case and a lot of experience with patients who have had less luck with pharmacologic therapy, who are unable to tolerate or unable to adhere to medications. Tell us about the case that you brought.
Yeah, so I was, as a cardiologist, I had some interest in hypertension when I started my program, and we didn't have a formal hypertension center, but because of this interest, I started getting a lot of referrals. And one of the first referrals that came in was an employee for a healthcare system. She was in her mid-50s. She had had a stroke in her late 40s, fortunately recovered, but obviously that portended a bad prognosis for her if her blood pressure wasn't taken seriously. And she is one of those patients where every time she started a new class of medication, there's something that really kept her from being adherent. And it was tough because she had seen multiple providers. She gave it her best effort, but she just felt unwell on many different classes of medication. So I'm a new cardiologist. I get this patient referred to me. My senior partners haven't been able to solve things. Her blood pressure in the office is 164/92. We like to confirm blood pressure similar to both of you outside the hospital. So we had an ambulatory blood pressure monitor, high 150s, high 80s. We went through the whole workup. We checked her for hypoaldosteronism. She had no real risk factors for renal artery stenosis. We went through, make sure she was taking all of her other meds as a surrogate, that she's adherent at least to when she tells me she's on a med, she actually takes it. And we were stuck without a lot of options. And this was before renal denervation. So my father was a retired cardiologist. I called him and I said, "You ever prescribe minoxidil?" And he said, "Oh yeah, I used to use that and it didn't work that well, but what do you want to know?" And I said, "Well, I need to start this." And so we started on minoxidil. It was the only medication I could find she had not tried. We started at 2.5 milligrams, made our way up to 10. We made the smallest incremental change in her blood pressure, 150/90. But worse off for her was she came in and she had hirsutism. She had hair in her face, hair in her arms, was shaving, and it was really quite detrimental for her. It's hard to be in public with that. And so we had to tolerate it for some time. And fortunately, when renal denervation was approved, we had the opportunity to do some of the first cases in the country, and she was the first on my list. And I gave her a call and I said, "We've talked about this in the past. We didn't know if it was going to move forward, but now we have this great trial data, FDA approval. Would you like to have renal denervation?" And she said, "I'll come tomorrow."
Yeah.
So we did the procedure. It was one of the first procedures in the country. It was a quick procedure. She did fantastic, went home the same day, no procedural issues. And as we saw her back over 1, 3, 6, and 12 months, we came down on the minoxidil, we came off the minoxidil, and we're sitting in the low 120s now, high 70s, well controlled. Just a fantastic outcome for a patient who's really struggled. And it wasn't a struggle because she wasn't serious about her blood pressure or dedicated to the medical regimen. It was just how her body responded to therapy. And I think those are patients we can't ignore. And I will treat patients who are dedicated like that. I also treat patients who have controlled hypertension but on 6 or 7 meds, and all they want is to come off a med or two. They want to make the regimens a little early. They want to get off the hydralazine, TID. And so we'll treat them even to reduce their med burden to try to make this a more appropriate and long-term program for them. And that's been really successful.
Yeah, that's also just a great case that I think illustrates the importance of bringing this to patients who have high cardiovascular risk, right? That's something that comes out in our guidelines too, right? Is that, maybe not every patient who's on just one medicine might be a candidate for this technology, but patients who are at high cardiovascular risk are going to get greater overall clinical benefit, and definitely something that we need to be thinking about when we have those conversations with patients. So we are now living in a world where you have patients who are getting this as part of clinical practice. We have an indication for use. We have guidelines to support the use. Eric, tell us a little bit about the current indications, maybe a little bit, just start the conversation a little bit about what our guidelines currently say about who might be eligible and how we should be picking patients.
Yeah, this is really important because, again, as Tiffany started, half the population has hypertension. So you can think that, the population that can be treated with this device is really quite large. But we know that's not how we should approach it. We should be finding the right patients, and we've really emphasized the 3 pillars that have gone through exactly what we do in clinical practice: lifestyle changes, medications, and then as an adjunct, renal denervation. And so the FDA, who took a really close look at the 2 approved devices, gave a indication for use for both of them of reduced blood pressure as an adjunct to treatment with lifestyle changes and hypertensive medications. When those do not adequately control blood pressure, then we should consider renal denervation. And I think that was the right way.
And as you alluded to, it's a very, very broad indication, right? But that's not necessarily all the patient population we should be looking at, right? How do we specifically determine who's a good candidate, and what do our guidelines say about that?
Yeah, I mean, we break this down really into 3 groups, and we've had some documents. SCI, SCAI's interventional group that we worked on to develop some algorithm for this. And I think of the 3 groups as kind of 2 of which we've discussed. Actually, all 3 is, are they on 3 or more meds that include a diuretic? Really, your ABD that you talked about at the beginning, that, or ACD, I'm sorry, that really can benefit from renal denervation because they remain uncontrolled on what we consider a high dose of medications. There are the patients who, as I presented, are intolerant and just don't have other options for managing blood pressure. And then the third bin is those are at high cardiovascular risk, had a prior stroke, cardiovascular event, diabetes, all these that enrich them for having a bad outcome for uncontrolled blood pressure.
And so in terms of those specific populations, right, resistant hypertension, intolerant, or unable to escalate their medicines, what other criteria are there out there that we should think about in these patients? I think they all came up in each of the cases, but Tiffany, if you can just elucidate on what our guidelines say about that a little bit more.
Yeah, I think another population that is discussed is patients who don't want to be on medications or who decide not to, right? And so for that patient population, even though certainly you can't necessarily say they're at the highest cardiovascular risk, and may not be the first patients that we're doing now that it's just becoming commercially available, but it is something to consider, especially as you think about the early trial data where you saw, people on no meds, they still did get cardiovascular improvement and improvement in their blood pressure control for that group. But I think it's important too to think about who should not be getting it, right? And so people who do have identified secondary causes should have those treated first, right? The guidelines are very specific about that. Also right now, not supported for people with stage 4 or 5 chronic kidney disease, under more investigation, but as of right now, not indicated for that group as well. Or people who have significant underlying narrowing of the renal arteries, prior stenting, all those things would be contraindicated as well.
And then, of course, we have the issues of shared decision making that are really, really important. So, Eric, you've been spending on, I know this comes through in all of our guidelines, the SC guidelines, the HA guidelines, this concept of shared decision making. I know you've got a lot of experience with offering this to patients. Tiffany talked to us a little bit about how she talked to her patient about it. How do you talk to your patients about it?
Yeah, I mean, I have a few important aspects. First is I, as a proceduralist, is somewhat biased. So I try to remove myself from some of the early conversations. And I have a wonderful partner named Anna Cuevas, who's a hypertension specialist, non-invasive, and I let her start the conversations. And really, we try to introduce it early into the conversation so people are aware that if we are not able to successfully accomplish our goals on the first 2 pillars, that this is an option, but it's not an option we're going to pursue right now. So the first thing is just giving them a little bit of education so that they're familiar with the term, they're familiar with the technology. If they want to look into it a little bit more, they can. And we have some pamphlets and stuff we hand out. But on average, I get a lot of referrals now for renal denervation. The minority go to renal denervation, and that's how we like it. We want the minority to be sent for a procedure and the majority treated with what we know has worked for a long time. Among this conversation, though, it happens over several visits. And usually we'll have 2, 3, even 4 visits before we're ready to send for renal denervation. And it's understanding the patient a little bit better. What are their preferences? What are they worried about? Are they worried about a cardiovascular event? Are they worried about not having another medication in their pocket that they have to take 3 times a day? And so that really helps us gauge where they're at. And then finally, when we feel like we've exhausted what we can do without renal denervation, we start to be more serious about the procedure, making sure it fits their goals, understanding the risks and benefits, and letting them, in the end, make the decision to move forward or not with that procedure.
Anything that you would add in terms of that conversation and a little bit about how your center works in terms of identifying patients?
Sure. So, one of the things that I think many of us who work in the world of hypertension are most thankful for with renal denervation is not only the direct impact of the procedure, but just the highlight that it's bringing to the management of uncontrolled hypertension. And so, we've developed a hypertension center comprised of myself, a nurse practitioner, a clinical pharmacist, and multiple other group members who help manage these patients both before and after the procedure, knowing that the majority of patients unfortunately still won't be controlled even after renal denervation. It's very important to have somewhere for them to have continuous care and to continue to work on all of the lifestyle and medication changes that still may be needed to help them get to goal.
That sounds great. Well, I want to thank you both. I think we've covered a lot of ground here today, right? I think I made a good case, because I think there's a good case to be made that renal denervation can be an important third pillar of therapy for patients with uncontrolled high blood pressure who are either resistant hypertension or unable to escalate their medications for other reasons. But obviously, it's important to select those patients well. We need to be considering their overall cardiovascular risk, their out-of-office blood pressures. We need to be ruling out secondary cause, and importantly, we need to be really listening to that patient voice and involving them in that decision making. I also love what both of you talked about in terms of embedding this technology within a system of care. That's been one of my just things I've really thought about from the beginning of this is how do we use this and leverage this technology to get better overall hypertensive control in our communities, not just in patients that we're going to denervate, but in patients who may not choose to get renal denervation. So I want to thank you both very much for your time here. I think this was a really, really great discussion, and I want to thank all of you for participating in this activity. I would ask that you please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.